I apologize for my voice. Luckily, I'm on the other side of this thing, so I'm feeling much better. It's just my voice has not come back. So medications, I think I pretty much know everyone here. So medications in the geriatric patient is a really important thing for many different reasons. Just from my own standpoint, this still tends to be the number one cause of serious errors. So in other words, when I look at all the information that, thank you so much, all of you, for putting in the information on adverse drug reactions, medication events. When I look at the most common cause for severe medication errors where there has to be an intervention, antidote given, a reversal agent, or sometimes the patient, there's a met team call, it's for medications being dosed incorrectly in the elderly. And we've worked a lot as a hospital on this. A lot of you are aware of the alerts you see in Pyxis. Physicians see alerts when they're entering orders into the system. We've designed our order sets so that the doses should be correct, and there's a lot of alerts that the pharmacists see as well. And we also have the medical staff agree on what should be the initial doses for select medications in the elderly. So first of all, who are the elderly? Who is elderly? So we need to come across a definition of elderly, because I know when we're standardizing things in the health system and we're talking with all the different pharmacies, they all have different, some of them have different ranges for what an elderly person is. So we have to look to see, is there a standard? And the standard is set by the American Geriatric Society. And they've defined elderly as age 65 or older. So we're pretty much on the safe side if we go with that definition, only because we're using something that is really out there. We just didn't make up our own. And so the Beers criteria, how many of you are familiar with the Beers criteria? Okay, so what the Beers criteria is a kind of group got together, and I'll explain a little bit more in detail, of healthcare professionals to try to improve the safety of prescribing medications in the elderly. And they adopted the American Geriatric Society definition of age 65 or older. And now the CMS interpretive guidelines have incorporated the Beers criteria. So in a sense, the CMS is saying that in relation to dosing of medications, elderly starts at 65 or older. So the takeaways from this is, after this, is just to understand some of the key issues in geriatric pharmacotherapy. So there are some technical terms I'm going to use, they're like totally pharmacist terms, but I'll try to explain them and try not to get too heavily involved in them. And then understand the effective age on medications in the elderly, which medications to avoid in the elderly, which to use with caution, understand which medications require reduced dosing, and the risk factors for adverse drug events, and ways to identify and mitigate them. So when we look at why are we so concerned with the risk of harm from medications in the elderly, other than our own data in our own hospital, is it pretty much reflects what you see nationally. So nationally, 30% of all medications prescribed are in patients 65 or older. Patients 65 or older have 7 times the medication error rate than those 64 or younger. And a lot of this is due to just they're on more medications. 20% of elderly patients discharged will experience an adverse drug effect within 45 days of discharge, and 32% of these are serious, 5% life-threatening. It's estimated that 20% of medications prescribed in the elderly are prescribed inappropriately. So, and a lot of that may not just deal with hospitals, but it deals with as outpatients, where patients may be seeing several different physicians who are prescribing several different things that interact with each other or duplicate each other. So, why are the elderly at increased risk of harm? Well, aging influences how we handle medications, and so how the body actually absorbs the medications, distributes the medications, eliminates the medications, is called pharmacokinetics, and also sensitivity to medications, which is different, and that's called pharmacodynamics. So some medications need to be avoided, others require lower doses. The elderly are less likely to take medications as ordered for a variety of different reasons. They're on a lot of different medications, and sometimes, and we're all forgetful, but the elderly sometimes tend to be more forgetful. And the risk for drug-drug interactions and duplicate therapy is more likely. Yes, of course, if you're going to be on more medications, there's a higher risk for drug interactions and duplications. Existing conditions or potential conditions may mask ADEs in the elderly and prevent detection. So when an elderly patient gets confused, often people think, oh, they're just getting confused, and people don't think, could this be due to a medication that they were put on? Or if they fall, or things like that. Also, there's a misconception of outward appearance in relation to medication dosing. So that still occurs where, and sometimes pharmacists will talk to a physician and say, this patient is 75 years old, they've not been on this medication before, the initial dose should be this. The physician will say, but they're a really strong 75. They're big, they're robust, they're very energetic. And that may be true, but does that reflect how their liver functions or their kidneys function? So no matter how robust and youthful you are at 75, your kidney's not going to be functioning the same way it is as a 25-year-old. So aging influences how we handle and react to medication. So a lot of this, I'm going to talk about a lot of different things here, and it's going to be a little confusing because it is. Because different things counteract each other. So sometimes you're really not quite sure how all of these things will play out. So absorption is different. So the rate of absorption for elderly with oral medications may be delayed, resulting in a lower peak concentration and a delayed time to peak concentration. So when we talk about peak concentrations, when you take an oral medication, and unless it's a sustained release one, that there's going to be a period of time where you pretty much get the big part of the medication and then it trails off, and before you go below a certain drug level, you give another dose. Well, that peak level a lot of times is lower due to delayed absorption of medication. There's also a difference in first-pass effect. So I'll explain a little what first-pass effect is. So only with certain drugs, such as metformin, morphine, these are orals, propranolol, diazepam, midazolam, lidocaine. What it is that with these drugs is when you absorb, you take it orally, there's a lot of the drug that gets absorbed in the gut lining, and when it goes through the liver, that never actually gets into the blood system to do what it needs to do. So drugs are pretty much dosed. These drugs that have first pass effect are dosed with young people. So with older people, they have a decreased liver mass and liver blood flow. So what this means is that they may get more of an effect with these drugs because less of them is being extracted before it goes into the bloodstream. Volume of distribution, what that is that when you ingest a drug, it distributes throughout your body. It distributes, blood, some drugs go into the fat, whatever. And that varies with the elderly. It's increased for some drugs due to a decrease in body fat and decrease in others due to a lower albumin with some elderly people. So there's a lot of different things in play here. And then, of course, we all know decreased renal function can lead to drug accumulation and toxicity for those drugs that are excreted renally or have metabolites that are active that are excreted renally, such as meperidine, which we try not to avoid. We try to avoid and not use. And then the elderly may have impaired orthostatic circulatory response. So this is an increased risk for syncope and falls. So this is the whole thing that a younger person, when they jump out of bed, they're fine. An older person, they jump out of bed and they're going to fall. So they have to sit on the side of the bed. So any of these drugs that affect your orthostatic circulatory response will, of course, cause a higher response in the elderly. So pharmacodynamic changes, so we talked about the pharmacokinetics, so that's how your body physically handles it. So your sensitivity, which is different, so that's talking about when it gets to an actual drug receptor, where this is where it wants to go to affect the change, are very complex because of difference in the elderly in receptor density, signal transduction, so it leads to a decreased homeostatic reserve, so that even potentially modest side effects may have severe consequences. And this is the takeaway, particularly with medications that affect the CNS. So any of the medications that affect the CNS, they're going to affect it a lot more in the elderly patient, such as the opiates, benzodiazepines, and psychotropics. So when we look at the drugs and their dosing in the elderly, we particularly want to be aware of, and in our medical staff approved guidelines, they're specifically aimed at those that are the opiates and opiate-naive patients, benzodiazepines and benzodiazepine-naive patients, and psychotropics. So just some guidelines and medication choice and dosing in the elderly. Avoid prescribing prior to diagnosis. So we try to do this anyway, but in the elderly, because they take so many medications, because they're sensitive to medications, because they have so many drug interactions, because they take so many medications, the last thing you want to do is add more medications unnecessarily if you're not sure what's causing this condition. So, you may need to treat for a very short period of time what is the problem in the patient, but you really need to do a diagnosis to understand what's causing that. Start on the low doses and go slow. So, everybody kind of knows this, but that's really important because sometimes we'll have a narcotic-naive elderly patient in pain. And someone will say, well, they're really in a lot of pain. That's why I ordered this high dose. And you know what? In 9 out of 10 patients, that might be okay. But you've got that 1 out of the 10 patients where you're going to give that high dose to, that you're going to have to call the med team. So it's a lot easier to start at a lower dose. If that doesn't work your way up. Risk versus benefit, and that's kind of the Beers criteria, which I'll go over in a bit, but we really need to take a look at risk versus benefit, which may not be that big an issue in younger people, but it is in older people, and also consider safer alternatives. So a lot of times in the elderly, what we want to do is we want to look for non-medication treatment before we go to medication treatment, just to avoid, once again, complicating things, adding more drugs that they need to remember to take, that they could take inappropriately, that could cause drug interactions. So Beers. Guideline for healthcare professionals to improve the safety of prescribing medications for patients 65 or older. It is not a substitute for professional judgment. It's a guideline. So all this is saying is, you really be careful about these drugs. Try to avoid these drugs. You may need to use them, but just don't immediately slap them on. Do it in a logical basis. It's accomplished through the support of the American Geriatric Society. There's a panel of experts that use an evidence-based approach with the Institute of Medication Standards. The Institute of Medication is that organization back in 1999 when there were reports in the media about young, healthy patients going to hospitals and dying, and other patients dying, and what's happening in our hospitals, that Congress mandated that they look at medical error in general, medication error in particular, and how do we improve the safety in our hospitals. So risks outweigh the benefit in the elderly when used as a first-line agent. So what they're trying to say is, we're going to show you those that you just need to be aware of. Because if you use them in an uninformed manner, you may unintentionally cause harm to the patient. And it emphasizes deprescribing medication, which is unnecessary health care. So one of the things, and I'm sure that a lot of you are aware of this, is what needs to happen sometimes, like with my mother or with your parents or with your aunts or uncles or whatever, is sometimes someone needs to just sit down and go, let's look at all the medications you're on. What are the ones you don't need to take? And let's try to take these things away, so therefore it's easier for you to take the medications you need to use. And, a lot of times when that happens, suddenly people start thinking more clearly, and they're not feeling as tired or whatever. And it promotes the importance of using a team approach, non-pharmacological approaches, closer monitoring of drug use. So in other words, in the elderly, we want to understand if whatever they're experiencing is due to either a drug or their condition, we need to monitor the drug use more closely. An application of computer prescribing interventions, that's just proven to be safer. By the way, everybody says, oh, it's safer, it's safer. In our own hospital, we actually show that certain types of errors decreased dramatically when we went to CPOE. True, other types of errors kind of showed up, but they didn't outweigh the benefit. And then better patient outcomes. So I'm not going to spend a lot of time on these medications because I'm going to show you a website you can go to that has all this information, and you can download it. You can make yourself a pocket of beers. But androgens, cardiac problems, of course, contraindicated in prostate cancer. So this is just saying you really don't want to use androgens in the elderly unless you absolutely have to. And it's kind of funny, just because I'm almost 60, when I was a pharmacy intern, believe it or not, they used to have this oral vitamin solution called Gebrabon that was for elderly males, and it contained testosterone in it. So obviously they don't make that anymore. Antihistamines, your first generation one, because of the anticholinergic side effects. So greater risk for confusion, urinary retention, cardiac problems. Anti-Parkinson agents, when used for prevention of EPS with antipsychotics. Obviously, if someone has Parkinsonism, you're going to treat them, but you try to avoid treating EPS with antipsychotics with these agents unless you have to. Antispasmodics, highly anticholinergic. Alpha-1 blockers, once again, orthostatic hypotension, which sometimes is very hard to, in certain patients, to control. The central alpha agonists due to the CNS side effects, bradycardia, orthostatic hypertension. Class 1A, 1C, and Class 3 antiarrhythmics. Avoid them as a first line of treatment for atrial fib. So what you want to do usually with elderly people with AFib is you want to control their rate. So you're going to use the beta blockers, your calcium channel blockers. You would even probably use digoxin before you would use these agents for AFib. Benzodiazepines, once again, increased sensitivities, falls, accidents. Barbiturates, they can, the patients can get stoned at lower doses. Digoxin greater than 0.125 milligram per day in heart failure. Estrogens, because of the cardiogenic potential, unless they're used for vaginal dryness. Metoclopramide, a lot of people know that, increased EPS. Muscle relaxants, sedation, risk of fracture. NSAIDs, now this is kind of interesting because usually it's 65 or older, the NSAIDs is 75 or older, just because of that's what the literature shows us. Oral antidiabetics such as glyburide and glimepiride have a prolonged half-life resulting in prolonged hypoglycemia. So I talked about like a number one med error in our hospital, or severe med error is the dosing of certain medications in the elderly. Our number one severe ADR is due to a lot of patients coming in from the outside on oral hypoglycemics. So they started out at a dose that was okay for the renal function, but something happened with the renal function, which decreased, and suddenly they come in with refractory hypoglycemia. And no matter what we try to do, they just keep having lower and lower blood sugars, and you can't dialyze these drugs off. So that's one of the things we see a lot. I don't know, in the ED you probably see that, once in a while coming in. And then tricyclic antidepressants, anticholinergic, sedating, orthostatic hypotension. Also to mention a black box warning in the elderly. Now, you're all familiar with black box warnings. So these are the things, like, in other words, when a drug comes out, they do all these studies, they say, here are the side effects, these which you have to avoid, whatever, don't use them in these patients. But then, later on, after the drug comes out, suddenly we find all these patients are dying because of this or really having problems because of this. They put out what's called a black box warning. Well, the regulatory agencies, for whatever reason, are very, very keen on these, almost to the point where they're not as keen as on the precautions that originally came out with the medication than to those that came out later. But nonetheless, a big one is not to use atypical antipsychotics, such as Abilify, Clozaril, Geodon, Seroquel, Zyprexa, for dementia or dementia-related psychosis. Studies show that the elderly that take these for dementia or dementia-related psychosis have almost a 2 times fatality due to CPAs and arrhythmias. So this is a huge one, and this is one we were actually visited by the state about 5 or 6 years ago. So this is one of those things where in pharmacy we try to look to make sure these things are being prescribed as they're supposed to. And it's really difficult if you've got someone who's coming in with both dementia and psychosis that are unrelated to try to ferret these things out. But nonetheless, and here it is. I think you've got handouts, right? So this is where you can go to. You can get all your information. You can download it. And then in addition to the beers, I had mentioned that we got our medical staff to all agree on what should we put as initial dosing for the elderly. And we actually did this before we started looking at the order sets, but it was very helpful when we started looking at the order sets because it gave us something to start with. So the big ones, Dilaudid, and once again, this is for opiate naive. If you've got an elderly patient that comes in and they're on MS-Contin, obviously they need a lot of pain relief. If they've got cancer or whatever. With Dilaudid, start at 0.2 to 0.5 IBQ 2 to 3 hours. Most hospitals are now going down to the 0.2. We're still saying at the 0.5 only because we found that seems to be good with our patient population. If we start to see patients who are elderly and that they were not on narcotics at home, they were on Motrin at home, and they're put on 0.5 and they start to get stoned, obviously we're going to revisit that. Morphine IV start at 2 to 4, and avoid long-acting preparations in the elderly opiate naive. You want to avoid long-acting preparations in anyone who's narcotic naive because you really don't know what their needs are until they demonstrate their needs over a period of a week or so. Nonetheless, with younger people, we feel a little bit more comfortable starting them on a longer-acting preparation if they've been on narcotics for about 4 or 5 days. With the elderly, we really need to be careful. Benzodiazepines, once again, we have those starting doses. And I always look at this, and I think of my father, who he's been deceased for 20 years, but when he was alive, and he was even in his late 60s, he got kind of anxious and nervous. And so my mother took him in, and his physician put him on a medication. And then my mother said, he is just out of it. And he's going downhill. I don't know what's happening with him. I go, well, what did they put him on? What did he put him on? And they said Xanax. I said, what did they put him on? Xanax, 1 milligram PO 3 times daily. So like, that's it. You get him off the Xanax, put him down to a 0.25 or whatever, 0.125, and that worked. And then psychotropics, our biggest use on a daily basis is Zyprexa. That's why I got that one listed there at 2.5 to 5 milligrams PO daily. Once again, you start them at this, then you can work up if you need to work up. But you just don't start them at a higher dose. So I'm going to talk a little bit about adverse medication events in the elderly. The main determinant to decrease the occurrence of ADRs in the elderly is the correct identification of an ADR. So this is where it comes to when you got an elderly patient that becomes confused and everybody thinks it's due to their current state, is to say maybe this is due to a drug. A lot of these things occur, and when I look at these events, I see a lot of opportunities. So I just saw one the other day where a patient went for a colonoscopy, and they got very agitated very confused, very delirious. And the GI physician was kind of like, I'm not quite sure what to do, but they were so bad that they had to go to the ED, and the ED had to treat them. And when I started looking through it, I thought, Demerol, they got Demerol, that's it. So it's some of those things that, no one, because, you're concerned with the immediate treatment of the patient, backs up and says, could it have been one of those drugs? Many ADRs are falsely ascribed to frailty, falls, delirium, drowsiness, lethargy, and that these actually could be due to drugs. And the inability to distinguish drug-induced symptoms often results in the addition of yet another drug to treat the symptom. So you've got someone who, say, is now kind of delirious and combative because they're on a benzodiazepine or something at a higher dose or an antipsychotic at a higher dose. So now we put in another medication to try to control them so they're not combative, when it was actually the dose of the first medication. And the more you add, the more complicated it gets, the more interactions, the more potential harm. When there's any acute change in a patient's clinical condition, consider medication. So it's just one of those things that you consider. If you got a patient and suddenly they're not as responsive as before, or they're sleepier than before, and I think most of you do anyway, you look, could it be a medication? They start on medication, did they increase the dose? Poor documentation leads to patients re-experiencing ADRs that they previously had. So often what happens is people think that an elderly person is experiencing an effect due to their elderly state when it's due to medication, because it's never really, no one really investigates it or documents it. That continues to happen. So in the case, even with the patient with the Demerol, it's like one of the first things I did is I went back into their record and put that in there just so the next time they come in, and if someone tries to give them Demerol, they will see that. Consult your pharmacist, notify the physician. Once again, if you're wondering could it be a certain drug, just call the pharmacist and ask them, could any of these drugs be causing it? And then document it in the patient record and in RL Solutions. So that's really important. What I often see is where there's an area of the hospital that doesn't use Meditech, and so they'll go in and they'll put an adverse drug reaction in to RL Solutions, and I'll call up Meditech, and it's not in there. Obviously it's not in there because they don't use Meditech, but I want to make sure that information flows over to Meditech, so if they're ever admitted to the hospital, someone sees it. Yes?
What anesthesia? Like we get a lot on anesthesia. Sometimes it's with anesthesia, and then sometimes it's venous that we give after.
Mm-hmm.
I suppose we put in RL.
Well, okay, I will tell you what, and that's a really good point, because I'm talking about adverse drug reactions. Now, an adverse drug reaction, the question is that when a patient comes post-surgery, they've had anesthesia, now they're on pain medications, and they have these reactions, should they be put into our incident reporting system? And what an adverse drug reaction, the definition is something that is deleterious, so something that is unwanted, and something that is unexpected. So yes, if it's unwanted and unexpected, put it in. So I'll give you some examples where we don't put it. So if someone is getting high-dose chemotherapy, where the patient's going to be super nauseous, we give them, medications to prevent nausea before they even get the chemotherapy. And if they get nauseous, it's expected. It's unwanted, but we know it's going to happen. But, if you get a patient post-op that's unresponsive or unable to get up, unable to do PT or whatever, that's really undesirable. So that should be put into the system, because then someone needs to take a look and say, hey, are we, are these patients coming from PACU too soon? Or are we giving them too much medications in PACU? Or are they getting, is there something with the anesthetics that we're using? So I would say yes. I mean, if you're expecting it, no, but if you don't expect it, yes.
We expect it in all of it.
Yeah.
I mean, just because it happens so frequently, but it's still a outcome with 2 and 3 and 4 days later, patients still.
Yeah, 2, 3, 4 days, yeah, definitely put that in. Definitely put that in. I mean, that's, okay, I will say, that's a lot of stuff, and it's one of those things where you need to take a look to say, I don't have time to put all of these in, but I do want to document these because I want someone to take a look at this. I want someone to do something with this. So maybe choose those that are worst case scenarios, those that are particularly difficult to start with, and then they'll get looked at. I'll give you an example of there's an area of the hospital, I won't tell what the area of the hospital is, where the physicians always seemed to be overdosing elderly patients. And the nurses felt very uncomfortable about it. And they were afraid of approaching the physicians because the physicians were not necessarily receptive to that feedback. So what they were able to do then, I suggested, why don't you put these into the system? Because they put them into the system and they put in anonymously, you can put them in anonymously, they were all sent for peer review, and physicians got tired of having all these peer reviews that actually changed the way they prescribe medication. So sometimes that works, but in this case, we probably want to take a look at the way that we're doing things.
But in most of these cases, the patients we're talking about already, the palliative team is already on medication. They're the ones managing pain. Really you have to draw a fine line. If you file, that's fine, but what are we trying to accomplish? You're managing patients' pain and it's already killed the system.
Well, yeah, and that's it. And if you're saying, we've got a really difficult patient here that is in really a lot of pain, and we have to, okay, and we really need, our first priority is to treat their pain, and we know we may have to take some measures that they may get drowsier than usual or whatever. Okay, we expect that. The palliative care team expects that. But it's one of those things where if you're not expecting it and that happens, you put yourself in the situation of even if you've got a young patient, and they may not be a post-op patient, and you come in and you can't wake them up and finally wake them up. I mean, you want to know if that's due to a drug. I want to put it in the system because we want to find out, maybe we're dosing this too high. Maybe there's a problem with the drug. I mean, that's the whole reason now why people avoid Demerol like the plague is because these things happen with Demerol. I don't know if I answered your questions, but so just a couple of case studies, and it's something that they're really easy. You pick up on them with a 91-year-old female with dementia on memantidine, which is Namenda, lisinopril, hydrochlorothiazide, and simvastatin, admitted for combative behavior. Given Zyprexa 10 milligrams IM and lorazepam 1 milligram IV, then placed on Zyprexa 5 milligrams PO daily, lorazepam 0.5 milligrams PO, TID, PRN, agitation. Now this happens. Patient's confusion increases and patient becomes more somnolent. So what the issue is here is they have dementia. So first of all, having dementia, being elderly, they're going to be very sensitive to things. Having dementia, they're going to be more sensitive. And then the doses that you were starting out were too high, and you start out 2 agents at once as opposed to 1. 81-year-old male admitted for low back pain. Discomfort, was on ibuprofen and atenolol prior to admission. After surgery, patient is placed on Norco 5 for moderate pain, Dilaudid for severe, soma, muscle spasms, and restaural PR and insomnia. Post-op day 3, patient falls on the way to the bathroom, states he got dizzy and blacked out. I'm sure you see that sometimes. Yes. So it's one of those things, too, that nurses are placed in a very difficult position because you sometimes need to give these medications, and each individual medication in this case is an appropriate dose for an elderly person. But when given all together, of course, they have an additive effect. But sometimes you have to give them because they can't sleep, because they're in pain, because they're having muscle spasms. So what we're going to do now is just kind of go through a little exam Just do it together. So which of the following medication doses must be lowered when initiating therapy on elderly patients? Yeah, A is true, but E is the best answer. E is the best answer. Okay, which of the following changes in the elderly would not affect medication dosing and response? This is a little tougher one, but... Give up? E. E is correct. E is correct because they have a decrease in liver mass, decrease in blood flow, which leads to an increase in bioavailability with the first pass effect. What is not true about the Beers list? A is true, that the Beers list is not absolute. It's a recommendation. Which of the following statements is true regarding adverse drug reactions in the elderly? D is correct. Elderly patients often re-experience ADRs due to poor documentation, sometimes being poor historians. So this is the thing when they come in and they tell you they're not allergic to anything, and then the daughter or son comes in and says, you cannot give them penicillin because they have this reaction. So, okay, any questions?